we are going to move on to Miss Sheila Otten. Her title of the talk is Beyond A1C, Integrating Mental Health into Pediatric Type 2 Diabetes Management. Ms. Otten is a licensed clinical social worker with Norton Children's Endocrinology, and she's affiliated with the University of Louisville School of Medicine. In her role, she provides mental health therapy to children's, teens, and young adults diagnosed with diabetes. She earned her Master of Science in Social Work from the Kent School of Social Work at the University of Louisville, with a focus on marriage and family therapy. Thank you, Sheila. Give the floor to you.
Thank you. Thank you, everyone, and thank you for choosing to attend our symposium today. I'm always excited to learn and see what everybody has to offer. Like Dr. Thrasher said, I am a licensed clinical social worker. I've concentrated on kids with chronic medical conditions or complex medical conditions probably for the last 10 years of my career. So I feel like I have a very good understanding of what families and patients go through with chronic medical diagnosis. So today I'm going to be talking about beyond the A1C and also integrating mental health with type 2 diabetes, specifically with adolescents. So here are our objectives today: to provide an understanding of the benefits of mental health with pediatric patients, also to provide information regarding the benefits for screening for mental health issues, and also to provide hopefully some easy techniques in engaging patients that are struggling with managing type 2 diabetes. So the prevalence of mental health and diabetes, I don't think I have to tell you there is a higher rate of mental health in anyone dealing with a chronic medical condition. If you take those challenges and also put a chronic medical condition like type 2 diabetes on top of that, teens today are dealing with a lot, social media, video games, isolation, everything else, in addition to managing a chronic medical condition, can leave them exposed or open to experiencing more mental health challenges. So the impact and challenges specifically. So the impact of mental health on self-management and A1C. So we see a lot of decreased motivation to adherence. They don't want to do the things that they need to do due to everything else. Also the regular blood sugar monitoring and also medication adherence. Lauren talked a little bit about that, of kids struggling to maintain adherence to medications that are important in managing their type 2 diabetes. A lot of kids that I deal with and I see already have the impression, especially those that struggle or are diagnosed with type 2 diabetes, they already think their future is already written about complications, that they're going to have amputations, they're going to lose their eyesight, they're going to have struggles with kidney function because they've seen other members of their family struggle with those too. So they think that a type 2 diagnosis is already a flash forward or whatever of what's going to happen in their future. And just working with them and explaining that they have the power to control that, their outcomes of health implications. Also, just general challenges, like I said, about being an adolescent. Ideas of autonomy, their own identity, what does that look like? Also peer pressure, and then family function and roles of authority also impact their ability to manage their type 2 diabetes. Kids at this age want to be like everybody else. They don't want to stick out. They don't want to be different. And having to take medications or watch what they eat or be mindful of exercise only creates more stress for them. So like Lauren said, and also like Dr. Watson mentioned as well, here at the Wendy Novak Diabetes Institute on the pediatric side, we do practice an integrated care model. We are extremely fortunate to have a multidisciplinary team where we have a medical provider, a diabetes educator, a dietitian, and also a mental health provider. Having a multidisciplinary team allows us to do routine psychosocial screenings, the PHQ-9 and the GAD-7. We screen at every diabetes patient over the age of 10. For those are important tools that our medical providers use and our staff uses. They may signal that they have symptoms of depression or anxiety or suicidal ideation. And we're fortunate enough to have mental health providers, myself and Nevada, our other LCSW, to provide care and support and treatment for those things. So targeted therapies for pediatric type 2 patients. This is important. I think this is one of the most important things to talk about. If you don't have access to a mental health provider in your clinic or readily available, these are simple things that could be beneficial in engaging a pediatric patient with type 2 diabetes. I think everyone's familiar with cognitive behavioral therapy, thoughts, feelings, actions. Kind of what are they thinking about having type 2 diabetes? What are they thinking about having to manage type 2 diabetes? All those things impact how they feel, which impacts what they do. If they have a negative feeling about type 2 diabetes, this isn't fair, I don't like it, why do I have to do this? Those are going to elicit feelings of hopelessness, of anger, of just frustration, and then they're not going to want to take care of their type 2 diabetes. Obviously, this can, have implications of other areas of their life too, but especially with kids who have type 2 diabetes. The other one is motivational interviewing. I'm a big fan of this technique or this intervention. It not only gets to the root of the problem of what they're dealing with, it also calls out cognitive dissonance. They want to feel better, they want to have a lower A1C, but they don't want to exercise, and calling out those things that are kind of against each other helps explore other options for that. Also, I believe motivational interviewing helps engage the patient in their own treatment and their own exploration of barriers to care. And it also creates a good relationship between the medical provider and the patient. The patient comes away feeling heard, feeling supported, also feeling validated. It is a struggle. It can be challenging. And I think for a medical provider to acknowledge that helps with, again, with the collaborative relationship that we want with our patients. Another thing that is extremely important in helping and supporting pediatric patients is also enlisting the family, which we're used to that in working with pediatrics, right? We deal a lot with family dynamics and our patients. So talking about communication, talking about support. What does support look like for a type 2 diabetes adolescent patient? What does a parent need? What the parents struggle with diabetes distress and things too. They can feel overwhelmed. Also too, creating that, having a diagnosis of type 2 diabetes creates that dynamic of, requiring things of a patient or an adolescent that maybe other adolescents don't have to deal with. So again, these three techniques I think are extremely beneficial in working with patients that have type 2 diabetes or really any chronic medical condition. So again, back to the motivational interviewing or understanding what it is that you're dealing with, it's important to know the differences. Their treatment options for diabetes distress and diabetes burnout look very different than, I don't want to say typical depression, but depression. So diabetes distress or diabetes burnout is actually a mental physical exhaustion from managing diabetes. They're tired. They attach a lot of negative thinking in the management of diabetes, which just becomes a lot to deal with. So they rationalize a lot why they aren't going to do it. I'll do it later. It takes too much time. And again, the typical, it's not fair. No one else has to do this. So that negative thinking can have a direct impact on their adherence to medication. Also, just irritability around diabetes care. Their friends don't have to do it. It makes them different. And feeling hopeless of having a chronic medical condition, especially the nature of managing diabetes. Again, a lot of them are already in that mindset, excuse me, that they already know all these negative things are going to happen. So kind of what's the point, right? Sorry. So this leads to diabetes, distress, and burnout. Again, depression is different than those. So the feelings in depression are typically universal. They are with school, with family, with friends. The overall of feeling hopeless. Things are never going to change, not just diabetes. Sometimes kids with depression will struggle with just daily activities, showering, eating, reaching out to friends, even sometimes playing video games or things they normally do that bring them joy, they typically will not do. Also just feeling general, like I said, malaise, lack of energy. Again, the most important thing is depression is universal. It's in several different settings, several different contexts, where diabetes distress or diabetes burnout is more just in dealing with diabetes. So again, understanding what it is you're dealing with, what you could think looks like depression might actually be diabetes distress and diabetes burnout. So how do we shift the focus off of just the A1C? Kind of what does progress and success look like? So there are things that we can look for or explore that aren't directly tied to what someone's A1C is. So check in about over quality of life. How's school? How's friends? Working, having a job, anything like that. Do they have anything they're looking forward to? Anything they've been successful in? I'm a huge proponent of pointing out the positives. Success in other areas, like I said. What about time in range? What about greater adherence to medications? What about even, taking insulin twice a day or is better than none? Again, focus on the positives. And we know from research, and we also know from personal experience, small incremental changes have a way of snowballing and creating a bigger impact. I can't tell you how many times I'll go into a room with someone who's newly diagnosed with type 2, and the parents are feeling overwhelmed. The patient is feeling overwhelmed because now they have to move more, they have to eat different, they have to do all of those things. And making huge changes in your life leads to feeling overwhelmed, leads to doing it for maybe 2 to 3 days and then forget it because it's too much. So like suggesting simple changes. I will typically tell patients, if you have stairs in your house and you're gonna go upstairs, downstairs, upstairs, park farther away from the door of a store or something like that. Again, the small incremental changes that they can do, feel success, and then that's gonna snowball. Back to the motivational interviewing, get curious about barriers to treatment. What is it? Is it stigma with peers? Is it anger about the diagnosis? Most of the time, what we think a child, especially a teen, is dealing with is not actually what they're dealing with. So we're going to spend a lot of time and energy trying to fix something that's not even relevant to what they're going through. So again, establishing that relationship with a patient that you can ask questions, you can find out what exactly is going on. So hopefully the takeaways from this presentation are optimal outcomes require addressing the body and the mind. We know mental health impacts physical health. If we're not, and I don't want to say happy, but functioning at a good level, at a healthy level mentally, we're going to really struggle to manage anything physically, not just in our life, but also within our body. Also, too, and I know it's been reiterated already, but fully integrated treatment team is a standard of care, addressing all of their needs from different angles. That's why I personally love being part of a multidisciplinary team, because I feel like we all bring our strengths, right? We all bring what we're trained and educated to do for patient care. Again, the routine screening, PHQ-9, GAD-7, PHQ-9 for depression, GAD-7 for anxiety. Also the diabetes distress scale I like to use because, again, it helps explore what patients are going through and what they're actually struggling with. Again, knowing what the struggles are impact how we can help address those needs. Also, the basic understanding, like I said, of those simple therapy techniques, those are ways that we can engage a patient, find out what's going on, and again, establish that relationship of collaboration. Again, if a patient comes away feeling heard, validated, and supported, they're going to be telling you more, they're going to be sharing more, and they're going to listen to you more because they don't feel lectured to, or talked down to, or judged. Also, too, just navigating issues. There are times in talking with patients that they don't want to take a shot at school because they don't have a place to take a shot, and problem solving with them at that. What are some places that you could do that, or understanding side effects that the patient's experiencing, maybe with metformin or other medications. Again, getting curious of what it is that they're dealing with. I think, again, I'm just going to say we can't address issues if we don't know what they're going through. That's all I have. Does anybody have any questions for me?
Thank you, Sheila. Yes, you have a couple questions in the chat box. Let me read them to you. The first one is, would you explore diabetes camp slash Camp Hendon recommendations?
Oh my gosh. So I volunteer at Camp Hendon over the summer. And I'm sure you already know, but I can't impress upon you enough how important it is for kids to be around other kids that have the same diagnosis. It is amazing to watch these kids just, I could tell you examples, numerous examples of how kids just being around other kids that have that diagnosis, that feel more empowered, that feel normal. I'm constantly told that week that they're the normal ones. I'm the abnormal ones. So I think that is important, just in building confidence and also just acceptance. Great question.
Perfect. Second question, how do you navigate a situation where the patient is motivated, but the parent guardian is not and doesn't want to help? Or when the parent guardian is motivated, but the patient isn't interested in change?
Oh, great question. I see that all the time when I'll go in and meet with a patient that's maybe experiencing distress or burnout. And it really is a communication issue. I'll ask the patient, so what would be helpful? I just want to feel supported. Okay, what does support look like? Well, I don't know. And then you talk to the parent and they're like, yeah, I hear a lot, unmotivated, lying, or whatever. I think being able to talk to them together and find out what it is the patient really needs, and understanding the frustration of the parent. I always like to say, you all want the same thing. We just got to figure out how to make that happen.
Thank you. Are there any podcasts, books, any social media um, references that you have that you'll give to patients or families to kind of help them on their journey as they're navigating through this process?
There's a couple apps that I like as far as mindfulness eating. My favorite one is called Meal. It's actually free. It's more slanted a little bit towards women. It's developed by women, but it has great resources in there and just great ways of understanding hunger and eating and stuff like that. I don't really know about podcasts at all, but I think anything that brings positivity to change, also acceptance. Not to that, there's that old saying that don't throw out the baby with the bathwater. You might have one day where you struggled or didn't do everything. That's okay. That's one day. Tomorrow is another day. And anything that creates positivity or anything like that, I think is more than helpful.
Perfect. Another question for you. Do you find new technology to be supportive or overwhelming for both the caregiver, the parent, and the child, with the example being like a CGM?
So yes, with to both of those. With new onsets, I like to tell parents who are getting a CGM and a new onset appointment, it's really easy to get obsessed with those numbers. And I like to say those numbers on a CGM is like a GPS. It's going to tell you what you need to do next. Also, I encourage people to have a family meeting about the CGM. How are they going to manage alerts? What lead time are they going to give their child that comes off at alerts at a high? Are they going to give them 10 minutes, 15 minutes? And this gives the patient an opportunity to step up and say, hey, I know I was high. This is what I did. And then again, that builds trust with the parents, builds accountability with the patient. Obviously, lows are completely different with that, but I have also worked with teens that feel overwhelmed with the CGM, that it's always in their face, it's always a reminder. And just in talking with them, I'll say, I know one patient in particular, how many times do you check your CGM? And she said probably between 30 and 40 times a day. And I said, would you poke your finger that often? And she's like, absolutely not. And it's like, okay, so talking about strategies of how to not check it every day just because you're bored or just because it's there. And also to the flip side, I encourage patients, that's technology that's going to give there to help you, to give you information, and then what are you going to do with it? So I think both sides of that, it can be cumbersome, but it also can give patients and families tools that they need to help be successful. I do know, side note, back to camp, talking with parents about disconnecting their CGM before kids go to camp is a really hard thing for parents to do, to kind of let go of that and know that they're going to be okay. And then we also have other parents that are very much looking forward to that week in the summer,
Yeah.
that they get to not be on call all the time. So yeah, great question.
And there's one more statement in the question and answer box. It's more of a statement though, so you can take a deep breath. But this individual just says, I think it's great that Norton has such strong representation of social workers in their teams. This individual is a nurse and cannot do her work at the quality that she can deliver without social workers. So thank you so much for your work and commitment.
Oh my gosh,
Very
thank
kind.
you. I appreciate that.
Awesome. Well, Sheila, I think you have answered everything. We thank you for your time this morning. Great job. And we're going to take a little break.